Okay, we have done the initial leg check and we found our patient had a right PD. PD leg lengthened in position 2. We started with possibility 1 and we've tested the knees and adjusted what we found in the knees. We still do not have the legs even in position 1. Therefore, by default, we're going to go to the OPD ilium to pressure test it. Protocol says that you test the OPD side first, thinking that there may be an AS there. We don't know till we test it. So we're going to pressure test it, which is in the direction of correction. So I'm going to the OPD ilium. I'm going to hook my fingers on the crest of the ilium and pull inferior medial to see if the leg lengths improve. Position 1 only because I did the test. The leg lengths did improve, so I'm going to set up for a correction. The first segmental contact point is the base of the sacrum. You know where the PSIS is, just palpate it and find it. You don't have to reach around and stand on your head like you did in try 1. Try 1, you didn't know how to palpate. Now you know how to find things. So just find that PSIS, go medial to S2, then superior to S1, and then lateral to the base of the sacrum. Your activator's in your superior hand. This is an AS ilium, so all the lines of drives are inferior. Anterior inferior on the base of the sacrum, top of the crest of the ilium, on the posterior aspect of your patient, not the side of your patient. Inferior medial, and you have the medial on the line of drive because of the angle of the SI joint, and ischial tuberosity, anterior inferior. Be sure to use a broad forefinger contact and take out the tissue slat P to A and place your activator on the posterior aspect of the ischial tube. If you do it like you did in try 1 and go up to the bottom of it, once you place your activator, you're on the femur. So don't go up to the inferior aspect. Come to the posterior aspect for this setup on the posterior aspect of the ischial tube. Then I go back and look in position 1, and the leg lengths are improved, but they're not even. So I need to see if there's a PI ilium on the PD side. So I'm going to hook my thumb on the sacrotuberous ligament and tug it posterior, superior, and lateral. And in position 1, the leg lengths improve. So I need to adjust for a PI. I'm going to pull her feet apart slightly so that I can set up on these contacts. First, go to the posterior aspect of the ischial tuberosity and slightly medial to the spine of the ischium. Place my activator inferior to the spine of the ischium, palm toward the ceiling. Drop your drop your elbow between their knees, and your line of drive is posterior, superior, and lateral on the spine of the ischium. Then about a thumb width superior from that is the sacrotuberous ligament. You'll feel the tautness of the ligament. Posterior, superior, and lateral. Very same line of drive. And then the iliac fossa. Here's her PSIS. Here's the crest, and there's the fossa. You're about an inch lateral to PSIS, an inch inferior to the crest, and the line of drive is anterior superior on the iliac fossa. Now I'm going to look to see, bring the feet together, and she's either going to be much improved or even. If she's either way, even or much improved, I'm still going to check the pubic bone. Pubic bone always gets checked after doing an AS and or a PI. So the test for the pubic bone is an isolation test, which is an active test performed by the patient. Everything we did up to this point was a pressure test that I did on the iliums and the knees. Now we're going to do an isolation test. And that test is done by having the patient squeeze the knees together. So patient is adducting in position 1, she's reactive. The leg lengths got worse, and in position 2, the PD leg got longer. So because she did the test, I have to look in position 1 and position 2. And then we use our short long rule. If the PD leg lengthened in position 2, you adjust PD side. If the PD leg shortened in position 2 or did not change, it stayed the same, you adjust the OPD side. So in her case, the PD leg lengthened. So if you need a visual, your thumbs are PSISs, your fingers are pubic bones, and we already corrected for a PI ilium on the right. So if she had a PI, then the pubic bone will be subluxated superior. So I need to correct for a superior pubic bone on the right side. Are you okay to roll over? Will you? So her right side just moved to this side of the table, so I walked to this side of the table. I'm going to go to the ASIS and then down the inguinal ligament to the superior aspect of the pubic bone, and the liner drive is inferior. There's a given that there's an A to P. The textbook answer is the liner drive is inferior. You can't use the activator on its side, you must use the tip wherever you're adjusting. Now, what if in position 2 the PD leg got shorter? If the PD leg got shorter, then we would go to the OPD side, and the pubic bone, if you use your visual aid, that side had been corrected for an AS, so the pubic bone would be inferior. So I'll correct for an inferior pubic bone on that side if that's the scenario of what happened. Are you okay if I reach across? Okay. For video purposes, I'll stand here. Normally I would go to that side. ASIS, inguinal ligament, anterior aspect of the pubic bone, and the liner drive is superior. Okay? Now, I let her roll over for the adjustment because I'd already read her leg lengths. I knew what I was doing, where I was going for the adjustment, and she rolled over. But now I want to recheck, so I need her from that weight-bearing position to go back down to evaluate whether we corrected it or not. So be sure that you don't put your hand on their chest, male or female. You're going to put your hand on their shoulder. And is that showing on the video? Okay. So you're going to support by putting your hand on their shoulder as you raise them up off the table. Okay, thank you. You can turn it off.